I wanted to start by saying, bringing up a story from last week's New York Times. And some of you may have seen this. This really brings home why information architecture and having empathy for clinical content and the translation of clinical content is so important. Did anyone see this, Lost in Clinical Translation? But it's so basically the story is this is from a book that a practicing nurse, Teresa Brown, has been writing. So I mean, she has a series of stories in a book, and one of the common problems that she encounters is the difficulty in communicating with her patients about the meaning of their treatment, the types of care they're receiving, and how that's so that they can really understand what's happening. Because that's a big part of self-care is understanding how to take care of yourself, what your treatment means, and reducing the amount of fear in the conversation. That's something that we can help with, I think, but what the story that she relates is that, or one of several, there's a flight attendant in her 30s had what appeared to be heart attack symptoms. And so she was grounded from her return flight and in a remote hospital on her own with people she didn't know. She went through a battery of tests overnight and discovered it was a pulmonary embolism. So she was with a clinical team that was explaining to her as clearly as they could what her treatment would require, why she needed to be there for a couple of days, and what the outcomes might be. Teresa Brown, the nurse, said to her, she was even a new nurse, it was very clearly articulated, and she understood it all, and she thought, well, you know, what could go wrong? And the patient turned to her and said, well, that was clear as mud, wasn't it? She didn't understand at all what was happening, barely understood what was required of her, why she was, what the tests meant, or what a pulmonary embolism really meant, that it was dangerous, was she going to, what were the risks? And so the picture that went along with that is, I think, very telling. If you remember Breaking Bad, if you remember Walter White when he's given his death, basically his death sentence of cancer, of lung cancer, and he is trying to assimilate that conversation with his oncologist, and he goes completely blank. He can't assimilate the conversation, and he points to a spot on the doctor's tie and says, you have something there. And that's the only thing he could muster in a conversation. That may not be too far away. So I think there's a role information architecture can play, and there's a role we have in understanding the context of people who are in healthcare and what I call health-seeking situations. So a little bit more about me. I've been working in this field in healthcare for at least 10 years, and in science and scientific evidence and healthcare-related information since the late 1990s. I'm also, maybe why I'm dressed like this, I'm a professor in the Faculty of Design at Canada's largest art and design university, OCAD University. So 5 years ago, we started a program called, as it became a university, they added university to Ontario College of Art and Design. So it's actually, technically, it's an acronym with university added to it now. But it's Canada's largest art and design school. When we started, we started one of the first graduate programs in strategic foresight and a master of design in innovation and foresight about 5 years ago. And that's grown as a program. I teach in that. We also are starting a master of design in healthcare design, which will be one of the first programs in Canada for healthcare design from both research, what's called evidence-based design, and we hope creative approaches to service design, information design in healthcare, because all these disciplines are needed. There's also, I'll make one more bit about the book. A lot of what I'm talking about is from the book, but the last piece about the book, if you don't win a copy of it, you get 20% off from Rosenfeld Media's website, which is actually at designforcare.com. So with the DFCWIED code, you get 20% off. You get the print book and up to 3 or maybe even 4 now versions of ebooks with that. All the images are also online. So this is a unique book in that it's the first book that I've seen, anyway. It's the first book that attempts to cover the different applications of design across the spectrum of healthcare sectors. So ranging from the consumer experience and consumer website information design to the patient experience, patient what I call health seeking, moving away from patient as an identity to all of us seeking health, the clinical information design, education, and healthcare systems. So it goes kind of from the individual all the way to the system level. The reasons for that is that if you work in healthcare, you've probably gotten very deep in one area and probably don't know very much about the other sectors of healthcare. So it's the kind of book I wish I had a few years ago when I could understand, so I wouldn't have to learn about the end-to-end experience and to research it on my own. So it's a way of trying to bring that end-to-end experience associated with the consumer, the patient, and the healthcare practitioner viewpoints. So it's the third book I've written, and over 10 years ago I wrote a book, Team Design, which I think I still keep in print, which is about facilitated and collaborative processes in team-organized design. So I was really appreciated Dan Brown's talk. I've been working in that area for a long time, and it's good to hear new viewpoints and collaboration. So just to finish up on the introduction, I have done a lot of information architecture, not so much recently as I'm teaching more, but I don't know if anyone, does that look familiar to anybody in the room? So in the early 2000s, well, that's how Science Direct looked in the early 2000s. I was a lead designer for Science Direct, actually the only information user experience designer in 96, 97 when it was developed. So as part of the development team, I helped Elsevier bring scientific content to the web. And a few years later, I've also worked with the information design and the product design for things like Procedures Consult for residency education around educating medical residents to learn surgical and internal medicine procedures, give shots, lop off bits, complete surgeries. And one of the things, so I've done a lot of field work, a lot of work in different hospitals, educational institutions, learning how clinicians and practitioners work with information, what they need to learn from us to make better decisions and to perform care. And so I believe that it's so I think one of the compelling ideas for us is that we can become members of those care teams, whether we're remotely or directly connected to IT teams in hospitals or working with agencies. If we're working in healthcare, there's what I believe is something like a duty for us to care about the outcomes of the information. So when I say care, it's not, of course, direct patient care, but helping practitioners make sense of the information, be able to communicate better to their patients, and to make better decisions in their everyday practice. And so I think we can actually think about it this way. Most practitioners actually view care differently, the different points of care, or what I'm calling in this case the touch points of care, the different places at which care can be delivered and information about that can be assisted. Every discipline performs care differently, so why can't a designerly approach to care be developed? And that's one of the missions, I think, of design for care, is that can be a way we can offer more value, or think about the end value towards health outcomes. So it's so the empathy for the content is about having understanding how clinical content and evidence content and materials like NCI were showing earlier, that can be designed in such a way that it can have more impact and can really communicate to the cases that the nurse Teresa Brown was speaking of, that even when we think we've communicated very clearly to patients and to trainees in the medical professions, there are so many different contexts for the communication of information. We need to be aware of those different touch points and how to better design for them. So I use this definition of what care is a lot. Milton Meyerhoff was a philosopher in the early 1970s, so it does have kind of gendered language from the 70s. But I think the key idea here is, and I think is that we demonstrate caring when we help a person or an idea to grow, to live, to thrive. And so it's demonstrated by our relationships and by the way that an individual can grow from the outcome of that information. So can information design help people feel cared for? Is there a way that we can have a more direct impact? If I'm losing... So there are three areas that I want to explore with this. We call it an approach to care-centered design. So the health-seeking experience, which I mentioned briefly and wanted to get into a little more. Patient-centered care, or what patient centricity is and how that relates to information. And clinical workflow, which is where you see it is a completely informed activity. So how practitioners accomplish what they do using information, how we can improve that cycle of things. So I like the term health seekers because none of us really think of ourselves as patients. If we think of it, there's a movement toward patient-centered care across healthcare systems in North America. It's probably global. It's been going on for about 10 years, and it's starting to really take hold. But it's still kind of an outside, or it's still an institutional perspective, the idea of being a patient. And we may not all be patients, but we all seek health in different ways. I don't mean that by trying to get better health necessarily, although that's part of it, but just in ways that we inform ourselves about healthier practices and behaviors on an everyday basis, how we connect to health information, how we seek information that helps our awareness, our growth, our ability to thrive. But when we're sick, or a family member is sick, or actually needs professional care, the level of health seeking will certainly go to the level of then having to become a patient. And in the book, I talk about moving from patiency to agency, because the whole idea of being a patient is that we're under the care of really the institution, or under kind of an agreement that we will take doctor's orders and things. And patients, and there's what's called the e-patient movement now. So patients are becoming more agents. But we don't really have the language to describe yet what this is. So if that's the case, if we're all health seekers, then the empathy for health-related information, that is how we design for how information is going to be used, needs to extend to all those different uses, not just to people who are specifically looking for cancer information for a family member, for example. And so the way we seek health or information, that is actually finding how our health should improve, is a sense-making process. It's not a decision-making process where we have a set of facts and it can kind of logically balance the factors and make a decision based on information we would seek. It's making sense of emotional context, of bits and pieces of facts, of evidence, and of things that show up in in various conversations. That is, we're actively making sense of the reality of our health. And it's a very slow process for some people. For others, sense making takes place at different paces. But the aim really should be, even of this approach to information, should be to accomplish better care. So not necessarily to inform, but to have the outcomes of growth or better care. And so where do we actually find care in content? So I have a persona throughout the book, Elena, and she starts in the first chapters taking care of her father before she has an incident. And so her father is recovering from cancer. He's a survivor. In fact, that makes the whole family cancer survivors. There's a view of patients these days that takes into account that everybody who's in the circle of care with a cancer survivor is themselves also survivors. They're very closely entwined. So we think about how the users of content in that context. That's certainly going to be the whole family. They're going to be relating to that. So I use fairly simple models or journeys of this persona to contextualize the different journeys, in this case, of seeking health from that context where she's where she's taking care of her father before she has an incident that is not diagnosed correctly at first, or is not fully diagnosed at first. So she has a fainting spell which looks like it might be related to stress or perhaps an early onset of diabetes. And so she's got a few other things that come together, but she actually has a cardiac arrhythmia called SVT, which isn't diagnosed until later. So over about a 3-month period, she goes through a series of encounters with different clinicians, from her primary care to specialist until that's resolved. And so at each one of those points, at each really touch point of interaction with clinical providers, with different care teams that are helping her at those different stages, she may have questions for herself and even with respect to her father now at the same time about different. She may have health information questions which relate to health seeking. So Angela Coulter, about 15 years ago now, identified 12, I think, very basic motivators which lead to questions for health information seeking. And they could be called patient information needs. And this is really a basic model that I like to start with. And they kind of follow in sequence from the situation that Elena is going through. So considering when she's taking care of her father, for example, she wants to understand her father's condition better. So she may be seeking public resources for that, things that are easily available on the web, working with her father's care team, finding out things from friends, social media, but then very interested as a kind of caregiver, identifying risks in treatments, helping weigh the different treatments or care options that might be suggested, so that she can inform herself, to be able to communicate with her father's care team. She wants to learn how to take care of her dad at home, and to be able to discuss things intelligently with the different clinicians, because when her dad is older and is going through all this treatment, may not want to be thinking all the time about what those options are, and may want to be in communication with a family member, not always with the care team. And if there's a big communication gap between the care providers and even well-informed people like Teresa Brown's flight attendant, maybe not really well-informed, but still people that self-informed still have significant gaps in understanding what's really happening in the types of complex procedures that happen in cancer and cardiac conditions, especially in complex care situations where you might have mixed where you might have comorbidities or a mixture of clinical conditions. And so the next stage is she gets into diagnosis of the underlying cause, the tachycardia, the arrhythmia. She now needs to learn how to take care of herself better. She has other health-seeking needs that she's going to be working with. She's going to need other types of information. There's no really one source that can address the self-care, learning about other services and sources of help, helping to cope, reassurance, getting hope that this is going to work out okay, connecting with other patients that might have the same things she has, being able to communicate with others about what's happening to her. Also, this legitimized seeking help. So I think these are really important concerns in healthcare. They may also be similar to other areas as well. That is, if we apply this way of thinking about information needs, information seeking from healthcare, could that apply in legal counseling, for example? Could that apply in family situations, family therapy, and other things? So a very basic kind of structural model for searching, printing, reading, making sense of medical information discovered on the web. I think the Elena and health seekers need to go, don't actually follow this type of canonical step-by-step process. That is, they may, observing people's information habits, information behaviors, we may see them run searches, view a few different sites, select some information, print out something to share and to read, but we have no idea whether it's really worked, how they're using it, how they may compare information from across different resources. So some of the top-ranked, the most popular health information sources available today includes the Center for Disease Control, health.gov, especially before it was the sole portal for Obamacare. It was actually a very important health information site, and WebMD. And I'm going to critique WebMD a little bit. This is WebMD from 5 years ago, maybe 4 or 5 years ago. And can anyone help me with this critique? Is there anything obvious that occurs to anybody here? I mean, it's remember, this is 4 years ago, so it's okay it's okay to tear it apart. So, any suggestions for what just really jumps out at you, or you think would be confusing to somebody who's trying to a health seeker is trying to locate information to inform themselves about an arrhythmia? And, yeah.
Well, the very first paragraph, I see it talks about an irregular heartbeat, but in that title it talks about abnormal and arrhythmia. Those are terms that a normal person probably don't even have an idea about.
Well, you have to wonder what they would search on. So it might be, are they taking a term from a doctor, and they're saying we think you have an arrhythmia. We're going to need to run some tests. Come back next week. So in that health-seeking journey, that's a few steps away. So let's say if she's knows now she's probably got a condition that's going to come out in tests, Elena is going to be nervously browsing this site. Well, I want to point out the mega levels of navigation that WebMD had here. And I don't know why they did it this way, but I mean, we're not usually designing to, so a global navigation, a breadcrumb trail, 6 tabs with 2 levels of text in each one, plus subtabs, plus article drop-down selection. And you don't even see the right-hand side, which was all advertising, and the left-hand side, which is also somewhat textually related. But let's say, if somebody this is part of the empathy that I want to drive home, is that if somebody's seeking information around a healthcare issue, and they're already kind of having some emotional concerns about what the diagnosis means, and they're looking for meaningful information that they have to read within a blur, and they're just surrounded by other links, other options, by other navigation. I mean, I would think they're lost in context in that last one. Well, I almost put that one in the book, and then they changed the website just in time to have this one. So I critique this one in the book, which is still criticizable, but it wasn't as horrible as the last one, or as the 5 years ago. But they have changed. They have updated a little bit. I kept at least the advertising here, but I do have to wonder why Salesforce is coming up under the type of search that.
It's not clear to me in either screenshot how the heart disease guide relates to the navigation on the top.
Yes. On the left, you have in arrhythmia, which gives you the overall context. The heart disease guide is like a separate, it's an entirely separate publication that is linked to overall issues in heart disease, some of which will have this publication as a subchapter.
But this is heart arrhythmia home.
Yeah,
And you're in the
Right.
heart disease guide, so you would think that would be a subset of arrhythmia. I mean, it's very.
And I don't remember whether this flips when you get to it, and then you have a related heart disease. So NCI should take hope that, because they were going in a much better direction than this, but this is the #1 healthcare information site.
Yeah, that was the point I was going to make, that WebMD is still the #1 health information site that gets a lot of eyeballs. Pretty much everyone, first thing that they do these days is go to Google and WebMD shows up.
That's exactly right. Yeah, they're going to get the most eyeballs because most health seekers are going to just run simple searches based on a few terms that they have and browse from there. If they believe that they can trust WebMD, then they're going to continue to return to that site. Consumers aren't going to know the level of evidence, the level of trust they should have in that. More informed consumers are going to know government sites. They're going to look for also well-branded clinics, things like that. But when you think about what we need to design to create, I mean, so some of it is how do we increase the level of trust in the information that we're providing. So some of it isn't just a matter of brand. It's the level of truth and the understandability of that information. So I want to show a couple directions that a doctor, a primary care physician, and an educator in Toronto is working with. Dr. Mike Evans, he goes by Dr. Mike. He's been on the radio, he has a column. So he's actually popular and well known in Toronto. Dr. Mike has been exploring alternative forms of media. In other words, empathy for content for his public, not just his patients, but a very large public, trying to reach people across Ontario and maybe even more broadly with information that is both easy to understand, factually true, and relevant to their different audiences. And so these are hockey cards. They have hockey cards in Canada, right? Baseball cards. So this is like in the Canadian context. And so this was it was meant to be primarily for children, for describing the medications that they might have, particularly in diabetes situations. So children who are diagnosed with diabetes have to learn an entirely new regimen of treatment. It's very burdensome. It's confusing. They have to change their lives quickly all at once, and life is never the same after that. So he created a series of these hockey cards, which are kind of actually more for the parents to describe. I mean, if a young child may not get it so much, but it's a way of connecting to a public audience. And that was about 5 years ago. About 3 years ago, they developed, actually 4 years ago, they developed a series on what they called cancer stories through Cancer Care Ontario and another organization. And so they ended up with a series of, at first these were produced by actors telling stories about cancer experiences, so that people people who had cancer diagnoses in their families would be able to understand the situation from from people who have gone before them at different levels of severity, different types of cancer. And then he found that it worked a lot better if these are more like mini documentaries. So he had the patients tell the stories themselves. So he created, continually innovated these types of content to, in an empathic way, to really connect with the larger community around issues that are very difficult to communicate with on a clinician to patient level. And so as a doctor, he hired a documentarian to interview people who had very compelling, heartfelt stories, some of which, so if you find this under the truth of it, or I think under cancer stories, it's a .ca domain, and they still keep those hosted. They're very findable up there, I guess. And then more recently, in the last year, he took a cue from the RSA videos, and he and Dr. Mike narrates this video, which as you can see is getting almost close to 4 million hits now in about 6 months, I think, or less than a year, on the 23.5 hours. It's what can you do in that half an hour? If you just had half an hour, what could you do to improve your health? And so this brief video is then live sketched like an RSA by members of his team in the health design lab, as they call it, at St. Mike's Hospital in Toronto. So I'd encourage you to actually look at that one, thinking about how people are finding health information today. That one is very discoverable because it's also been promoted through social media a lot. It's health promotion. It's more population health oriented rather than addressing a particular condition. But these are very findable as well. And so you can see integrating these types of resources into more traditional text content as well. So I want to kind of wrap up this section with a summary of what I think we might be able to do to help designing for care, helping people grow and feel cared for. I mean, there are a lot of things. That level of connection isn't easily measurable. I mean, 4 million people may have seen video on health promotion in 23.5 hours, but we don't know how people are using what they learn. But so we need to, from a remote distance, still have empathy for how people are going to participate with that information in a way that will help them help care and help them grow. So first of all, we have to be spot on, accurate. We can't have errors in the information. The usage of terms needs to be vetted. So there usually needs to be a clinical overview of it's good to have a clinical review. In fact, probably imperative if you're writing in this area. You need to understand, so we want people to understand in their language, in their terms, so that translation is not trivial. So translating so that people, so NCI showed us a complete Spanish language site. I'm hearing more and more in the research that I do around patient-centered care that there are other languages that show up in different regions. They're around the US and in Canada. And so sometimes different Asian languages are now so prevalent. Medical information is not easily translatable to some of those cultures and contexts. And so that's a challenge for us. So I mean the recipient. So this information needs to be validated by the individual's conditions of knowledge and truth. It has to ring true for them. It has to speak. It has to be not just from the institution, but make sense to them. So having real and relevant cases is very good if you can have that associated with the information. Being able to give people action steps without being so prescriptive that it's it's this way or no way. You can't do that with information, and actually anyway, unless it's information to the clinician. So you have to be able to afford the appropriate actions. Multiple media, multiple mediators. So video, images, animations, different forms of text. These are all important to allow people to adapt to their style, their tempo, their location, and matching the information to their channel, and facilitating sense making that I had mentioned before. There's a reference to that if you're interested, who writes a lot about sense making. There's Brendan Durbin, who's written a lot about how people discover information in ways that they use, in ways that we can't understand. The way people make sense of things is going to be unique to their experience. It's not an objective process of resolving facts. So at this point, I just also wanted to ask if you had any examples of, from your experience of creating translating medical information for end users, for patients, or for working in a consumer healthcare context, would run into these challenges, or yeah.
I was wondering, could it be a two-way street too? Because the internet also provides a platform for patients to come on and maybe on forums discuss their symptoms and their treatments with other people.
Indeed, yeah. Well, sites like Patients Like Me, which are used not by a vast number of people, but are, I think, a couple of 100,000 dedicated users of Patients Like Me are communicating with in disease communities. It was started for Lou Gehrig's disease, so ALS, which doesn't have a lot. It isn't a very large disease community, but it's been underserved. So some of these underserved kind of disease communities have bundled together and have found access online where they have unique knowledge about their situations, and they're sharing a lot. A lot of the more conventional, shouldn't say necessarily conventional, but widely spread conditions, cancers and cardiac conditions are you won't find the same patient communities as much as you find in these more specialized areas. Diabetes, though, is a huge support network, and there are a number of different diabetes platforms. So I think that's really an area that we could, that I think information architecture needs to support as well for the translation of evidence that can help them. Because if people go to those sites and they're sharing their own experience, that may not be the best way to vet the evidence that can support some of their decisions. So it may not necessarily be the most trustworthy. Yeah.
We've had to try to do a wizard approach, a question and answer, and users don't actually want to do that. They don't want to spend half an hour answering questions about their medical condition in order to get the correct advice on their condition. So instead, you're left with very general advice that go see your doctor because we can't recommend anything. The use case is people want to come in.
For like diagnosing a particular situation.
They want to see the symptoms. Okay, these are the symptoms. Yes, I have these symptoms. These are the treatments.
And
they do want to do decision making. They don't want to do sense making, and that is the whole problem. I mean, the videos. Yeah, if you want to see, oh, I feel so bad because I have cancer. I want to see other people so I can feel better. Then they will watch the video that does the sense making that says there are no exact treatments for this type of cancer. And there's no way, and you can't necessarily expect this is your recovery time and you'll be fine by tomorrow. There's all sorts of problems. And yes, you can see that in the video, and that becomes a sense-making process, which is what they should be going through. It's also very hard to test that sense-making, whether they've done it, because you have to have specific goals.
Because it all gets integrated. By the time you actually,
you can't
test that situation.
You can't do just reading comprehension. Did they understand what was in the video? Did they understand this paragraph? You have to have a general goal that they have to realize in general that they cannot get one treatment fits all. That may be your general goal. So then you have to design the site, all the information to convey that general goal and see if they get that. That's very hard to test. It's very hard to set up requirements for your site that have that general goal.
Well, but I think that's a real challenge to design any type of tree or propagating structure for health information. And people generally do just search and then browse from there directly. So it's yeah.
I mean, I think to answer how can we help the health seeker, I think it depends on where they're at in their condition. So when you first get the if you're trying to self-diagnose, which is talking about again, then you're gonna
people do.
look at those symptom websites and find all kinds of stuff that they probably don't have. But then if they do get a diagnosis, then often the question would be like, well, who's the best doctor? What's the best treatment? And
what
there
else
are ways to get that information, but a lot of that cannot be found online, or you need special access to trees to get to some of the treatment steps and that sort of thing. So,
And people don't know how to locate trustworthy information at that level. So they're kind of stuck with WebMD, maybe some government sites, and piecing it together, making sense of what they have. Then they may not know what questions to ask from there. So it's another big challenge for us. I think a good one. Yeah.
So I think a big part of this is it depends. And so, for example, in my own health seeking, I have an 11-year relationship now. I never knew I'd last 11 years with my healthcare provider, and partly because a lot of what they do is very, very usable and also very, very integrated. So not only do they have a handy app for the smartphone that's useful for contacting the doctor and getting a question forwarded to the doctor.
Or just in your relationship, in your situation?
Yeah. But also in their clinical setting, they have pretty good integration so that they're tying in as well, and it kind of turns into knowledge management that they know me and they know how to look up quickly what's going on. And then if I need to do sense making, if I need to do some other things, it's all kind of virtuous and integrated.
It sounds almost like an ultimate case. I mean, I've come across very few. I've heard that there are clinics and situations like yours. I haven't actually come across one. That's one of the best. The idea of integrating with almost a personalized app that's almost like prescribed. Yeah, I mean, was it given to you by basically through the clinical relationship then?
No, it was just referred as one way to have 24/7 access to stuff
Oh,
that I might
yeah.
have been doing on a website. It was built into an app fairly well and seamlessly. That it's really the same set of records management that they already have on me from a long relationship.
See, so some of that has been developed over a long period of time. That's I think good. And yeah, one more then.
I just interesting the challenge with personal health records.
Yeah.
Because I've been involved in a couple projects with that. There's this tendency to put everything in a dashboard and give everyone everything.
No, Google's right.
Yeah, and you need to,
You gave up.
A, you need to be able to understand the data that being presented, but B, you're taking on tremendous responsibility, assuming the order of their own personal health information and how it should be presented. It seems like there's a real need for collaboration beyond just handing that sort of a topic or a problem or a project over to a firm to design.
It's related to that.
You work with that?
I had personally that experience when I went from one doctor to another. I asked for my records. It was 200 pages of
Paper.
style
Of paper.
PDF.
Oh, okay. Oh, almost worse.
There's no standard. There's no way to access the information. There's no way to search it. It's not even like accessible.
Yeah, it was just scanned. Or either paper or PDF that's scanned like that. So that's your personal health record. And what Google did at first was expected that you could basically store that information. If you wanted to manually enter the fields and create your own database, you could. So people laboriously constructed that, only found maybe a year or two later that Google was going to wind down that experiment. And it was just not sustainable. So there are huge challenges in this, in the, I guess, patient, certainly in PHRs and the patient health records, but also EMRs are not consistently integrated together across other record systems. So it takes a long time. It is taking a long time. Okay, one more.
Yeah, I've had patients who really distrust their doctors. Let's say they get 3 opinions. Each of them says, if I go to a cardiologist, I have a heart problem, right? If I go to a podiatrist, I have a foot problem. What is the real problem? So how do you recommend that patients find a source of objective information and pick the doctor to trust?
That's a different type of information problem. I think we need it's more of an analytics across multiple providers, across longitudinal tracking. So I mean, I'm not an expert in that area, but to me, it seemed that from the other studies that we have to be able to track outcomes better across patients, clinics, and institutions, and in ways that those can be used by the consumer, not just insurance companies. And so but that's a good question. It might actually get to this dealt with a little bit in the next section. So patient-centered care, and what that's the differences that this movement is making in healthcare industry. So if we think about information being provided as a care service, that is, we're providing, not just in the translation, but I mean, IAs are not medical writers, but there is a way in which we ought to be closer to the translation of evidence content to the different points of use. And today there is still a significant gap between medical evidence and its use. And the e-patient movement, which I mentioned before, has been very active over the last, well, before they were even called e-patients, activist patients for, I think, since the early 80s, when they were first starting to try to break into medical research. It's always been very hard to get to, even in universities. Medical research or medical journals are expensive, and so they're closely guarded. In the advent of open access, now a lot of this information is being made available, but there's something like about 1 million biomedical articles published every year across all the journals. It's just too much. It isn't translated. It's written for peers. Doctors publish to be, well, researchers and clinicians publish for every purpose other than communicating to the public. None of these journal articles are written for public access. And so I think we ought to be pushing for a different type of information form. We need different translations and different summaries of information forms. So Elena, when she gets into the cardiologist office now, might be, for example, interacting with an electrophysiologist, a cardiologist, telling her the summary of her tests. She may be getting, ultrasound scans that are, so she's getting multiple tests, multiple readings, and those get assimilated and described at the end of her day of tests by a cardiologist who is then giving her some options. So from a patient-centered point of view, so we had these patient information needs. At this point, there are kind of different needs on a different journey that I would point to. So once she's in a patient context, there may be different types of sense making. There's the touch point she has now are actually with, so when she's with primary care clinician, she may actually be working with, she may need information about nutrition, helping her understand nutrition and exercise, dealing with health beliefs, that is, what does she believe is happening, what other decisions have, or what other conditions she may be dealing with that she needs to work with together. So this is from the clinician standpoint. We need to find ways to communicate a patient-centered point of view in the communication between clinicians to the patients. And so at the different touch points, especially when they get into specialist care or meeting with cardiologists, patients are usually just given, it can be very complex, so they're given very clear orders, medications, steps to follow, but it's much harder to have a patient-centered, empathic conversation at the specialist to patient level. And so that's a huge area of need, I think, is patient-clinician communication. It's a major area in patient-centered care. And we look at the way, we look at the information that clinicians work from to try to provide treatments, diagnoses, to communicate to patients. One example is from the Joint Commission's protocol, which I like to use because this is very clearly written to doctors, but it has, from a patient-centered point of view, it has maybe only one line in the 40 bullets that supports a patient-centered approach at all. I mean, this is, so this is for the universal protocol for catheterization. So it's a procedure that's conducted all the time. It's basically a checklist for doing that procedure cleanly and perfectly. But only one bullet even suggests, and that's what it says circled in there, involve the patient. And if you look at the information, it's got a useless image. I mean, it's just 40 bullets. They actually don't read these things. So it's all the way because they learn them in med school and then they practice them. It's kind of a checklist that is glossed over unless there's a point that really needs to be used as a reminder. I've tested these things. I've tested checklists and the protocols. And if you've read Atul Gawan's work, you know these are important. And they're still generally overlooked. And some of that is the way that they are, it's the information presentation. It's the IA of a document like this. So what else could we do? I mean, there's a lot we could do. But certainly we need to be able to prompt for the patient context, to be able to point out if we're going to have a checklist, we should, and especially if it's going to be an interactive checklist, we need to find ways to prompt the clinicians for the things they need to check with the patient, to create a relationship, to have interaction. We could use everything from brief personas to the touch points across the procedure, checking in with the patient, prompts for the types of language, ways to ask questions. There's a lot of things that we could do to help relationship building, check their beliefs about the procedure and what they think might happen. There are other things that you probably may be familiar with or would suggest. I mean, we can do a lot better. And so one of the attempts to, a recent attempt last year, IDEO and the California Healthcare Foundation worked together with about 10 of the large electronic medical records providers and some other kind of major players to try to improve the continuity of care. It's called Project Synapse. And this was to deal with what's called the continuity of care document, which is, so Elena on her health journey is going from primary care to specialists to being an inpatient in a hospital to get treatment for tachycardia and an invasive procedure within her heart, guided by ultrasound that requires an overnight stay. And all those procedures, or all those steps, need to be communicated from physician to physician. So they use a continuity of care document, which is usually just very cryptic, and the patient never sees it. And sometimes things can go wrong. So this study this design process, done in an intensive workshop by IDEO, was to deal with these kinds of issues, the episodic and disjointed care issue. Now, how do you really improve the continuity of the relationship? How do you pass information from doctor to help the patient? And can we report that information to the patient as well so that they can understand what's happening on the different stages of their journey? So one way is to visually show what's going to happen as they go through their different appointments, and to have information clearly presented. This is really an overview of the concept. So this doesn't say what the patient would see, but it shows the patient needs, represent information that I care about in a way I can relate to, help me cross-check facts, and then physician needs as well. So this is the proposal for a joint document. This is one of several web proposals that IDEO suggested. And so this is the values to the patient could be suggested in an integrated and very colorful view. And so the final one is if we look at then how this might relate to clinical workflow, to clinicians themselves. There are many different points of care that doctors have to work through, and they differ based on their level of training. They're between med student to a senior doctor. The information needs will differ very much between their situation or their role, their level of training, and the service line they're in. So, if we look at the canonical workflow, that is what all physicians generally do as workflow. Health IT is generally designed to meet these steps along the way. at least 4 of them really deal with information that needs to be related back to the patient very clearly. And certainly explaining treatments, following up with the patients, helping them understand those procedures. When we look at the day in the life of a specialist, or even primary care, but of a specialist for sure, they're in operations or in rounds throughout the day. They may be studying, going to seminars at night, but they do most of their information work in the first hour of the day, or maybe even the first half hour. And they may be using 6 or 7 different resources, and so they're basically packing in all the information they need to carry out the rest of the day. And they aren't as mobile as we think in terms of using mobile information resources. They're at the point of care. They aren't looking up things unless they absolutely have to, unless they're in training. And so this is and this is from 2006, but EHRs still look that bad. And their access to information still is that complicated. So if we look at it, this is typically what is displayed after a link from the EHR, or a link, even whether it's mobile or a web site for a clinical resource. It's basically a journal article or a summary set of bullets that links to journal articles, or something like CardioSource or UpToDate, which is the most popular point-of-care reference that's used. And so there's a way in which doctors are like jet fighter pilots. So in clinical decision-making, you have very short period of time to make sense of information and to apply it. And in tactical jet fighters, there's something, jet pilots, there's something called the OODA loop that the Air Force has developed as a concept over the years. And so I'm relating a tip on empathy for clinicians from them. The OODA loop is the acronym for Observe, Orient, Decide, and Act, which is what a tactical fighter has to do very quickly to identify, to observe a situation, decide whether that's going to be a tactical concern, to make a decision, and to act or withdraw on that issue. And in most cases, doctors have a similar type of time pressure. They have less than 3 minutes to update their knowledge on any situation in their workflow. Often they may just have 30 seconds, and I've heard that especially from surgeons and other specialists. If I have 30 seconds to look up your resource, what are you going to tell me? And in that 30 seconds, we need to basically complete an observe, orient, decide, and act cycle. So they will have observed, they're going to orient with the information, and then they're going to settle that through with some sort of action. So our information needs to help that OODA loop. And so what can we do with an under 30-second loop? And then you can add the complexity of the situations that senior doctors are dealing with. They are operating at a sense-making level. And then if you look at medical students and residents, they don't have the background of experience. They're generally taking rote decisions. And there's a small body of research on this. I've done a little work on this, comparing rote decision-making, which is what our resources usually support, which is take these steps. If you see the situation, take these steps. But complex situations and senior doctors don't work that way. And so we need to look at matching content to that rapid information assessment point. So ways of orienting, deciding, acting, so if we look at UpToDate, it helps us in that it's got a long, detailed title, but it's relevant to the context, but it's not a very good clinical workflow. So just to finish up the last couple of points here, we need to design services and better information resources at the different touch points, information touch points. I think we can democratize better. That is, we focus a lot on websites. We talk a lot about mobile, but where patients and clinicians actually are. In the hospitals, they aren't using mobile as much as we think they are. They're testing them out, but there are so many. They need big screens for a lot of this information. And so I'm saying at hospitals, mobile displays are still, a big question, and we need to more just responsive information display, but responsive service design for health seeking. And I think that there's a way that we can bring care for information to the rest of us in well-democratized ways. I would say this care context is not exclusive to healthcare, and there are different ways to look at care across the other areas that we're working in. And so I haven't started to do that very much yet. I'm still very much I mean, it's still just a new, these are still not settled in healthcare. But if you can help me with that, I'd like to talk with you about that. So again, there's a book discount. You can reach me at these points of access, and I don't know if I have time for a question or two, but I guess I'm the last one.
We also have happy hour. Will you be around for happy hour?
Yes, I will. But while everyone's here, can I take a question?
Sure.
Well, who haven't I heard from? I get used to that. Yeah.
Sure. So medical anthropologists talk a lot about the cultural challenges of communicating to a patient, because what a doctor says might not necessarily be what a patient hears.
Yes.
Especially, like, there was this really extreme case, Spirit takes her and she falls down, or about a mom patient who her parents just were not hearing anything the doctor said, and vice versa, and sort of the tragedy that can ensue. So I wonder, with this democratization of data, making it more freely available on the web, how we can responsibly account for the fact that that people might not be hearing what we're saying, no matter how well we say it. And when you take the face-to-face interaction out of that, there's no way to gauge that.
Yeah.
So how can we?
It's a big question.
Responsibly account for that?
It's a big question. We just need to start opening up different ways. Maybe we've been talking a lot about metadata today. If we can have meta organizations across different resources. If there, for example, the way Google organizes your search results to try to push you to the things that are going to score better. What if we had meta organizations for clinical information that index the right sites, and we were able to do that as a kind of service? And so there could be some translation, some scoring, and that could be end user scoring, that could be support scoring. Clinicians could review that level of organization. I mean, I think that's a huge problem. We need to find creative ways to organize around that. I think our job is very much translation, but I think that's a big part of providing information care.